chronic productive cough, recurrent pneumonia, wheezing with brown mucus plugs, progressive exertional dyspnea. We are looking at a rapid-fire sequence of high-yield buzzword symptoms that you absolutely must recognize instantly. We are diving straight into this explainer of the source material to master the exam-facing decision logic for pulmonary pathology. No filler, just the core mechanisms, chronological disease progression, and the precise diagnostic steps you need to secure the right targeted management. Let's map this out. When your patient presents with restrictive pulmonary function tests and a low DLCO, or they've got a history of occupational and antigen exposures, your mind needs to immediately categorize the pathology. The exact same rule applies for hyaluronidenopathy, signs of pulmonary hypertension like right-sided heart failure or daytime sleepiness, or complex pleural fluid analysis. We are going to lock down the exact preferred tests, first-line treatments, and the critical exceptions for every single one of these presentations. Looking closely at this high-resolution CT, which, by the way, is absolutely your best diagnostic test for this condition, notice the total lack of bronchial tapering and the distinct airway wall thickening. That definitively points to bronchiectasis. You want to pay special attention to the signet ring sign. That's where the dilated airway is visibly larger than its accompanying artery. You can also clearly see the tram track sign, which indicates severe permanent airway dilation extending right out into the peripheral one-third of the lung. So what's the underlying mechanism here? It's permanent airway dilation resulting from a vicious cycle of chronic infection, severe prior airway insult, and impaired mucociliary clearance. Clinically, these patients present with a chronic production of voluminous, purulent, and sometimes even blood-tinged sputum. On your physical exam, listen closely for crackles and look for digital clubbing. And their pulmonary function tests, they're going to definitively show an obstructive pattern. Etiologies range all over the place, from cystic fibrosis and primary ciliary dyskinesia to immune deficiencies and localized airway obstruction. For management, it relies heavily on daily airway clearance techniques and mucolytics. Bronchodilators can be used if they're helpful, but you absolutely must deploy targeted antibiotics to suppress bacterial overgrowth and treat acute exacerbations. Moving over to allergic bronchopulmonary aspergillosis, or ABPA. I want you to picture a patient with difficult-to-control asthma or cystic fibrosis who presents with recurrent wheezing, brown mucus plugs, and fleeting pulmonary infiltrates on their imaging. This condition is driven by fungal spore colonization that triggers a massive, localized allergic inflammatory response. Your key diagnostic clues are severe eosinophilia, an extremely high serum IgE, we're talking often greater than 1,000, and positive Aspergillus-specific IgE or IgG. Treatment has to be aggressive. You must use systemic glucocorticoids to blunt that allergic inflammation, and you'll often add antifungals like itraconazole or voriconazole to directly reduce the spore burden in the airways. Let's flip the script and talk about restrictive diseases. The classic presentation of interstitial lung disease is progressive exertional dyspnea and a dry cough, coupled with fine inspiratory Velcro crackles on exam. PFTs will definitively show a restrictive pattern. That means low lung volumes with a reduced DLCO. These patients suffer from exertional hypoxemia much more characteristically than hypercapnia. A high-resolution CT is required here, and it's going to reveal fibrosis, traction bronchiectasis, and end-stage honeycombing. You've got to confidently contrast idiopathic pulmonary fibrosis against secondary causes, things like occupational pneumoconiosis, connective tissue diseases, drug toxicity, radiation, or chronic hypersensitivity pneumonitis. Speaking of hypersensitivity pneumonitis, this is a distinct immunologic reaction to an inhaled organic antigen. Think bird droppings, moldy hay, or hot tub exposures. The acute presentation features abrupt onset fever, chills, cough, and dyspnea. Interestingly, this often self-resolves when the patient just leaves the environment. But if you miss this acute phase, it leads to a dangerous chronic exposure. This is an insidious presentation of progressive weight loss, severe fatigue, and diffuse reticular interstitial opacities causing irreversible restrictive disease. Management demands strict, absolute antigen avoidance. For symptomatic or chronic disease, systemic glucocorticoids are your first-line treatment. Take a look at this classic bilateral hilar hyaladenopathy on the chest X-ray. This is the definitive best initial test for a patient presenting with shortness of breath on exertion and a dry cough. In a typical test-style vignette, the demographic is often a young African-American female. On physical exam, you might hear occasional fine rails, but notably, there's a total absence of wheezing. When you see this widened mediastinum alongside right and left hilar lymphadenopathy, sarcoidosis should immediately jump to the very top of your differential. But remember, sarcoidosis is a multi-system granulomatous disease. It doesn't just stay in the lungs. Patients can present with erythema nodosum on their shins, anterior uveitis in their eyes, hypercalcemia, and even right upper quadrant pain due to liver involvement.
Definitive diagnosis requires a biopsy, often of a lymph node, demonstrating poorly formed, non-caseating granulomas. But you only do this after you've carefully excluded infections and malignancy. Now, if a patient is completely asymptomatic, the correct action is simply to observe them. Treatment with systemic glucocorticoids like prednisone is strictly reserved for patients with highly symptomatic or organ-threatening disease.
Let's cackle the exact diagnostic workup for pulmonary hypertension. It's categorized into 5 distinct groups. Group 1 is your pulmonary arterial hypertension. Group 2 is driven by left-sided heart disease. Group 3 by chronic lung disease or hypoxemia. Group 4 is chronic thromboembolic disease, and Group 5 is mixed. Your exam-facing logic dictates you always start with an echocardiogram. If the diagnosis is unclear after that, move to a right heart catheterization to measure exact pressures. Finally, you must order a VQ scan specifically to rule out Group 4 CTEPH, mainly because it is potentially curable with surgery. Now, Group 3 pulmonary hypertension is directly caused by chronic hypoxemia, which triggers sustained pulmonary vasoconstriction. A massive driver for this is obstructive sleep apnea. You're looking for a patient presenting with loud snoring, witnessed apneas, daytime sleepiness, obesity, and resistant systemic hypertension. Left untreated, this cascade leads to pulmonary hypertension and right-sided heart failure. The definitive diagnostic step is a polysomnography sleep study, and your management absolutely must focus on treating the underlying respiratory driver through weight loss and CPAP therapy. Okay, let's dive into infections, starting with recurrent pneumonia. A sharp anatomical distinction is your very first step here. If the pneumonia keeps recurring in the exact same lung lobe, you must search for a local anatomical issue. This means extrinsic or intrinsic bronchial obstruction, like a neoplasm or foreign body, or recurrent aspiration, which frequently hits those dependent lobes. If a patient presents with a dependent lobe infiltrate, foul-smelling sputum, and a cavitary lesion with an air fluid level, you are looking at an anaerobic lung abscess from aspiration. Conversely, recurrences in different lung lobes dictate a search for systemic issues, things like HIV, common variable immunodeficiency, or cystic fibrosis. And as a quick rule of thumb, if a new pulmonary infiltrate combined with a fever arises more than 48 hours after endotracheal intubation, you must immediately suspect ventilator-associated pneumonia. This diagram brilliantly illustrates the critical mechanistic effect of gravity on intrapulmonary shunting. In a patient with unilateral pneumonia, the affected lung has incredibly poor ventilation. If the patient lies with the pneumonia side down, gravity physically forces increased blood perfusion directly into that poorly ventilated, diseased lung tissue. This drastically worsens the VQ mismatch, exacerbates the intrapulmonary shunting, and causes a severe drop in systemic oxygenation. The fix? Simply rolling the patient so the healthy lung is down improves their hypoxemia almost immediately. When a chest X-ray reveals pneumonia accompanied by a pleural effusion, you have to follow a strict diagnostic pathway. If the effusion is small and the patient has zero respiratory distress or hypoxia, you can manage this safely with oral antibiotics and close outpatient monitoring. However, if that effusion is moderate to large, or if the patient exhibits any severe respiratory distress or hypoxia, your next steps are immediate. You order an ultrasound, escalate to IV antibiotics, and prepare for therapeutic and diagnostic drainage via thoracentesis. Once you drain that fluid, the chemical analysis dictates your very next move. After using light criteria to establish the fluid as an exudate, you need to look directly at the pH and glucose. An uncomplicated parapneumotonic effusion is just sterile inflammatory fluid. The pH remains at 7.20 or above. A complicated effusion indicates actual bacterial invasion into the pleural space. That bacterial metabolism heavily consumes the local glucose and drops the fluid pH below 7.20, often with an incredibly high LDH from neutrophil lysis. Finally, if there is outright bacterial colonization resulting in frankly purulent fluid, it is classified directly as an empyema. Let's lock this in with a rapid, high-yield diagnostic rule for pleural effusions. A positive gram stain and a positive bacterial culture are the definitive markers that distinguish an empyema from a complicated pleural effusion. This is a critical distinction to make on your fluid analysis, but the clinical action remains identical. Both a complicated parapneumonic effusion and a frank empyema absolutely mandate prolonged antibiotic therapy combined with immediate, complete chest tube drainage.